Hello, ladies and gentlemen. Welcome to this webinar on laser therapy, which is hosted by Mano Medical, part of the Genia Group. So just before handing over the presentation to Dr. Ron RIEGEL here, I will say a couple words about the company and what we do. So for those who don't know us, Mano Medical is a company working specifically in the veterinary field since more than 20 years now. It's not a big company. We're about 20 people, live in France. And Genia is a larger veterinary group present in many countries, specialized in a lot of different things, a lot of consumables, but also some capture, protection, grooming and orthopedics material. So to say a couple of words, so Genia is a family-owned company founded in 1945 in France. Today, it is a very big company manufacturing more than 2,500 product ranges for more than 75 countries. And today, we have branches in France, US, Hong Kong, and Australia, which allows us also to get top insight into the global veterinary market. So our consistent goal is to provide veterinarians with quality products that elevate the practices and improve the comfort and the hygiene of the animal, and ultimately the animal welfare. So the Genia Group today is presented by daughter companies in different areas of the world. So we now have a company in the US, Genia USA, based in New York. We are obviously present in the European zone with the headquarters of Genia and Mano Medical in France. And also there is a big daughter company of Genia in China called Zimia, which ensures part of our production and promotion and also distribution in the Asian area, and also a Genia Australia company. So now Genia, including Mano Medical, represents 125 people on the 5 continents and 5 autonomous daughter companies. So now to talk about our today's topic, laser therapy. The precise topic is using laser therapy as an integral part of your pain management regimen. So this is our today's topic. This webinar is part of a larger series, so 3 of which have already been done in through 2021, and 2 more will be coming next in June and September 2022. So it is important to notice that all the replays of the webinars are available on our YouTube channel. Usually they are available within a day or 2 after the webinar, so you can sign up to our YouTube channel and you will be automatically informed by email when the replay is available. And so it will be for this webinar also. Now, regarding the questions that you may have during the webinar, there is an area in the interface called questions where you can type in your questions during the webinar. And if we have enough time at the end of the webinar, we will answer as many questions as possible. And if we don't have time to answer some of them, you can also send them by email to the email addresses that we will share. So to introduce to you our today's speaker, so Dr. Ronald RIEGEL is a co-founder of the American Institute of Medical Laser Applications in 2009 to provide education on all types of medical lasers in both veterinary and other healthcare professions. So he's an author of more than a dozen papers and books on equine anatomy and both equine and companion animal therapy modalities. And he was also co-editor of the textbook Laser Therapy in Veterinary Medicine Photobiomodulation, which is a kind of a Bible of laser therapy for those who want to dig into it more deeply. So thank you for your attention during this brief presentations. So if you have any questions, you can email our representative Remy Fresheville at the email address that is displayed on the screen right now, or contact us by phone in Europe or in the US. And now, Ron, let me
switch.
Let me switch to you so that now I will not talk anymore until the very end.
Well, just talk and tell me my screen's up so that I know. Yeah. I found it interesting that your company, Genius, started with a plexiglass syringe. That was their first product in 1945. That was, you know, from one product to 2,500. That's something. Yeah, somebody.
Yes, and back in time, it was very innovative, and which is a still a reference now.
Yep. Okay. All right. So you can still see me, correct?
Yes, I can.
Okay, good. I'm trying to arrange all these windows that have on my screen here. Okay, well, I'm going to get started here. Hold on. I'm going to try to get rid of some of these. Anyway, you can still see me, correct, Remy? Yes, I believe so. You're not, I think you turned your audio off. Okay,
yes,
perfect.
You are still on.
Anyway, all right, perfect. Welcome, colleagues, veterinary technicians, veterinary nurses, practice managers, and all those interested in laser therapy onto a topic that's dear to my heart, laser therapy as an integrated part of your pain management regimen. And this webinar is for those that have maybe are considering buying a laser, but it's also, there's a lot of information here for those that already own a laser. And basically, I'm hoping the take-home messages here is to give you several pearls of wisdom that you can use in practice starting tomorrow on how to integrate it into your current pain management regimen. Okay, there we go. So I have a few things to disclose first. Again, he already mentioned that I am the co-founder of the American Institute of Medical Laser Applications. That is the textbook that I was the co-editor on, and that was actually published, I think, almost 4 years ago now. I think it's on its 6th print run, actually. And I do a lot of papers, and I've taught, basically, I've had to very blessed to be able to lecture all over the world and learn a lot from all our colleagues all over the world. I'm a fellow in the American Society of Laser Medicine and Surgery, a member of the Optics Society, and a photobiomodulation board member. And just to clear that up, laser therapy is photobiomodulation. The medical profession adopted the word photobiomodulation 5 years ago, I believe. So that if you hear me use that, it's interchangeable. It's synonymous with laser therapy. It means the same thing, but photo, bio, you know, light, life, change, photobiomodulation. They felt that that would be a better descriptive term. And I'm a member of several medical and veterinary advisory boards for several different companies now. And again, thank you to Mano Medical for allowing me this opportunity to share my information with you. So a little personal history on me with therapy lasers, and if you've seen some of the earlier webinars, this is going to be a little repetitive for you, but there's some new people here, I think, that need to know. I did own my own practice for over 25 years. I bought my first therapy laser in 1979. So I'm going to, you know, give you in an hour here would probably took me years to figure out on my own through trial and error or learn from somebody else. So I've been at this for a long time. And again, the first laser that I bought was 1 milliwatt. So it was basically the 5th of the strength of a laser pointer that we use in lecture now. We didn't have laser pointers back in 1979. And I progressed through different strengths or powers of lasers up through the year 2000 when I basically was given a prototype of a 5-watt laser, and then in 2004 a 13-watt laser by a company to use. And basically I had to prove, I knew the theory was good on how this worked, but at that time, back in those days, we really didn't understand all the mechanism of action of these lasers. And I'm going to actually go through a lot of that today when we're talking here. And I co-founded AIMLA in 2009, and AIMLA is basically an education platform. We have a website where you can go on and take online courses. You can take a laser safety officer training course. We have a course just for veterinary technicians and veterinary nurses. And we have, also on the human side, we have a lot of human courses also. So that's what I found in 2009, because I was very disappointed we were having a lot of lasers coming on the market, but nobody was willing to educate us on how to use them. So I thought, okay, that's a niche that I can fill now that I sold my practice, and that's how I got here today. So we're going to, again, go through what laser therapy really provides to your patients and your practice, some fundamental information on wavelength and power, pain management, my definition of that, and the definition of the profession in that in veterinary practice. I'm going to go through the mechanism of action on the pain pathway, on how a laser actually alleviates pain. And then I'm going to go through a lot of protocols to integrate it into what you're already doing in practice, and that maybe as an adjunct to some of the other modalities that are using, or some of your pharmaceutical options. And then, of course, a lot of clinical applications, integration in the surgery, acute and chronic applications. And then last but not least, a couple of slides on basically what I know to be some of the average charges. Those things are, basically based on the average of all over, and that's going to, depend greatly on the region or the area geography of where you are. So what is the clinical outcome of laser therapy or photobiomodulation? It's easy. You get a relief of pain, a state of analgesia. How long does it last? Depends on the patient, depends on the condition. You get a modulation of the inflammatory response. And again, by modulation, I mean you still have all 4 stages of the inflammation, but they're shorter in length. So things, progress a lot quicker than they would otherwise. And of course, you get an increase in the microcirculation, and therefore an acceleration of the healing process. And that's really what got me excited about it way back in the late 70s. I wanted something that would speed the body up to heal, that didn't have any side effects to it, and basically could only do good things in the body. And I, learned really early that this was a possibility, and then over the years, learned how to use this tool. So let's talk about first some penetration parameters. We have to get the light to the target tissue. When you're talking about pain management, you're talking about nerve tissue, but no matter what you're trying to treat, we still have to get the light there. So it has to, there's some parameters here that are absolutely essential here to get consistent clinical results. We have wavelength. You need a wavelength. The higher the wavelength, the deeper it'll go into the tissue. And wavelength determines the depth of the tissue. Now that depends on basically a lot on the density of the areas that has to penetrate through, but usually wavelengths anywhere from 750 to 1050 nanometers are going to be sufficient to go that. When you get lower wavelengths than those, they really don't penetrate very far. Then power determines the number of photons at that wavelength that reach the target. In other words, if you have, and I'm going to show you some examples of that, but basically the more power, the more dosage and the amount of power that you're applying to the skin, the more saturated that tissue is going to be, and power determines that saturation. And of course, you have to give the appropriate dosage, which we bumbled around with for 20 years, basically, until we decided to come up with some, appropriate doses that everybody was using. And it was amazing. I had 31 authors for that textbook, and without any prompting or any guidance whatsoever between myself and my co-editor, Dr. Godbold, it turned out that every single one of those authors, their dosages were very similar to the other dosage that the other authors give. You have to have, enough treatments. You can't just expect to treat them one time and have them get better, because laser therapy is cumulative in effect. So in other words, you get a wow maybe the first time, but not such a big wow the second time, and it builds on that over time. And then utilizing the proper technique. You can't laser something 5 feet away. A lot of times I hear all these different stories about, I have a laser that I could stand on the side of the fence and laser the whole entire herd of cattle, stuff like that. That's just not true. You have to use proper technique, and a lot of it is basically on contact or off contact, and making sure that the photonic energy has enough power density at the skin to penetrate that tissue. I've got this illustration off of a colleague in Japan, oh my gosh, 12 years ago, probably 13 years ago maybe. And what I like this, because what he did was he took milk powder, and he mixed it with water. So you have protein, fat, and carbohydrate in this solution. And then he exposed a laser to it when it was in a clear glass container here, so we could actually see what happened. So if you keep this in mind, when you're treating things, you see that if you're absolutely perpendicular to the skin, that is what the beam is going to look like as it goes down through the tissue. You're going to have that white area in the center, right underneath that arrow, that is very dense, has a very high power density, almost like you're holding a flashlight right next to the wall. And then as you get out there, you can see that power dissipates. So think about that and visualize that every time. And you can actually see on this thing that all the way at the bottom, you can see where some of that energy actually made it all the way to the bottom of the container. Now, what's lacking in this picture is some kind of measurement, how many centimeters that is, how many inches that is, so people could get a reference here. But I think the main thing I want you to do is remember how that dissipates in the tissue. And of course, it varies by density and everything else, all those other parameters. But if you think about that when you're applying laser therapy, it'll give you a good guide, and you can imagine what it's doing while you're applying it. So let's talk about, light transport in tissue. The important parameters are power, radiance, in other words, the number of photons that are going to be available, and then dosages is the tissue saturation, and the wavelengths, again, are about the same. But what I have here is an example of a 0.5 watt, a 5 watt, and a 15 watt laser. And you can see that basically the difference between power or wattage or dosage and a radiance is dosage is what is applied to the skin, whereas a radiance is basically a measurement of the light as it passes through a certain level of tissue. So at the bottom and all through that milliwatts per centimeter squared is actually basically the power density or the irradiance that's passing through those tissues. And as you can see, when we go from a 0.5 watt up to 15 watts, how much more energy is delivered at depth. You can see if you go all the way and skip right to the bottom like everybody does, you can see that at a 0.5 watt laser at that depth, and again, those are not anything specific, this is a general illustration, is only 0.04 milliwatts per square centimeter, whereas when I get to the 15 watt laser, it's 1.2 milliwatts per centimeter squared. So look at all the big difference on the amount of energy that's supplied down there. So hopefully that illustrates what I'm talking about there a little better. And again, dosages are expressed in joules per square centimeter, and it's basically a radiant energy received by a surface, at the surface per unit area. And radiance, again, is the power received at a surface at depth or that passes through that tissue. It's actually power density. So with any given tissue, the light's radiance at any depth is proportional to the dosage that's administered and the power behind the laser, okay? Now let's talk about pain. I think this Galen was a Greek scholar, physician, philosopher, I found out, and this slide I borrowed from Dr. Robin Downing, who has been talking pain management since I've known her for probably 35, 36 years now. And basically, divine is the work of relieving pain. And that's part of our profession's mantra. I mean, we took an oath for that, to do that. And I think this sends it home is, so pain is basically a sensory experience caused by an actual event that basically, we elicit protective motor and vegetative reactions, and you even learn to avoid it. And it may modify our species-specific behavior and social behavior. In other words, it's something that we experience. It's a perception. Pain is a perception. And our patients can't tell us how they feel, but observation, provides us a reasonable indication a lot of times on their extent of their pain. Okay. And again, I've got reference through all this, but if you do any kind of research here, you're going to find that there's more papers out on laser therapy, photobiomodulation, low-level laser therapy, whatever you want to search, than there are on ivermectin. And ivermectin, as you probably already know, won the Nobel Prize. So when people say that this is not scientific evidence-based medicine, they just have not looked, because there's plenty of scientific evidence-based here. Now I'm not having my slides go. There we go. So we want to measure patient's pain. Yep. And again, here we want to, there's a lot of ways to do that here. There's a lot of pain scales. There's a lot of pain grading charts. I've used the Colorado Acute Pain Scale and the canine and feline. I've used canine brief pain inventory. I've never used the Helsinki Chronic Pain Index, only because the research projects I had did not use that, and maybe that's not used as much in this country as it is over in Europe. The Glasgow Composite Pain Scale has been one of the oldest ones that's around and still one of the best ones around. And then, client-specific outcome measurements. So we have a lot of ways of doing that. We can measure their behavior. We can see how they act. Do they act like they're in pain? You know what you act like when you're in pain. So the same thing goes for our patient. Common signs, facial expression, hopefully not laying there, vocalizing their pain. That means they're in a great deal of pain. And, again, visual assessment. How are they standing? Do they stand offloading their weight on one leg? Do they stand, crooked? Do they, compensate when they walk? Do they compensate when they move? Our physical exam, of course, has always been our standby, basically standard of care, that we give a good physical exam and we basically palpate and use all our senses to examine every part of our patients. And in the last few years here, I have been involved, well, actually since 1985, involved in infrared thermography. And I'm going to show you an example of that, because that is another way to measure and assess your patients in pain. And a picture's worth 1,000 words, because your clients, if I tell them, okay, I just palpated this joint and there's 20% difference in range of motion between this area and that area. I mean, they just look at you like you got four heads. But if I show them this picture and they see this bright white and red and yellow spot on the right side of the periarticular musculature there on our patient right there, you're going to say, wow. And what that is that's an area of hyperthermia, or an increase of an area of increased thermal emission there. And those correlate directly with inflammation or infection. Something's going on there. It says, look here, there's something going on there. And people can see that. You can't really see pain, but you can see possibly an area where that's being, basically coming from, and especially your clients, they understand that. So when you're talking about, doing something that they're not familiar with or anything, it's always good to have them fully understand what you're doing so you can do it. And like I said, pain management is central to practice. It's not an adjunctive therapy. I mean, alleviating pain is not only a professional obligation. I mean, we took an oath. And it basically, it contributes to our case outcomes. It contributes to our clinical success. And basically, when you have success, your clients love you. So you have a veterinarian client-patient relationship that is strong. And it identifies your practice as one that is committed to compassionate care, optimum recovery from illness, injury, surgery, or enhanced quality of life. And there's been a lot of papers starting back in 2015. Mark Epstein was one of the gurus of pain management. Him and Jamie Gaynor both had guidelines, many guidelines of pain management in the practice. And just actually within the last 4 or 5 weeks here, the American Animal Hospital Association pain management brand new guidelines came out for the dogs and cats, and that reference is there for you to, go look it up if you so desire and see what's new in the world of pain management guidelines here. And again, there's a lot of studies out there, but all the way back to 2006, basically they found that if your patient is suffering and in pain, it responsible for a number of chemical and neurological change, which if untreated can lead to dire pathophysiological consequences. In other words, with multiple organ systems. So we don't want our patients in pain. We want to manage that pain. And it's, if you think back to the last time you were in pain, I mean, if you alleviate that pain, you immediately started to get better. And if we don't do it, it basically lingers, and your whatever disease or pathology you're experiencing seems to go on and on. And it's been said that stress kills. One could better summarize that unalleviated pain, no matter what the cause, is a prime component of patient mortality. And that's true. I mean, go to some of our nursing homes and things and just take a good look around, because you'll be surprised how much that is true. So I used an illustration here, and I basically blotted over some of the things here so I can easily illustrate this. So what happens here is you have basically up there on the left-hand side, I have cell damage tissue injury, and everybody can see that. And what happens is when that happens, you get a release of inflammatory mediators. In other words, there's a whole bunch of inflammatory response of different biochemical products. And our nociceptors convert this inflammatory soup, I'm going to call it, to a nerve impulse. And that signal basically at that end of that peripheral stimulus there is a transduction of that signal. And then that signal is transmitted to the spinal cord, where it's modulated and changed several times, and again transmitted up the spinal cord to the brain. And that's actually where we have our perception of pain. So this chart, I thought, made it really easy to understand what happens here. And I've got some things here that may be of interest and help you understand how laser therapy fits into this whole scheme. So right now, anything that blocks various biochemical or physiological responses along that pathway is the goal of all our pharmacological and adjunct modality pain relief. So let's take non-steroidal anti-inflammatories for an example. We reduce the production of arachidonic acid and inhibits the prostaglandin release. These are antagonistic chitozymes. So we want to make sure that those are done. And then our exogenous opiate morphine works to agonize the mu receptors in the brain, spinal cord, and periphery. And that's very strong. Of course, comes with those is some side effects, especially the opioids. Local anesthetics such as lidocaine basically stop the flow of sodium ions, decreasing the depolarization of the receptive fibers and therefore interfering with the signal transmission. And that's why it's called a local, because it happens right where those nerve endings are in contact with that inflammatory soup, as I called it. So let's take our pain pathway now, and we've got a tissue injury, which has resulted in inflammation and mediator release, and our non-steroidals basically lower the prostaglandins level there. So that affects right there. So it's that lower rate basically modifies that initiation of the response to pain. Our local anesthetics work locally right there at the periphery. And then our opioids work on the spinal cord and the brain. So that's their main area where it works. But, again, opioids work on a lot of different areas in your body. That's just a very simplified form here. So now what I thought I'd do is I'm going to show you the biochemical and physiological cascade events that result in the reduction of pain when you apply laser therapy. So we have a biochemical cascade of events. We got an increase in nitric oxide production, which is a neurotransmitter, an increase in beta endorphins. That's our body's natural morphine, more or less. We get a decrease in bradykinin levels, again, an antagonistic substance mediator. We get normalization of the ion channel, so you get good flow of calcium across the ion channels there. Here's a biggie, serotonin release, very important to the veterinary profession because of its effect on basically several of our dermatological disorders. And we all love our serotonins. I mean, they make you feel good. We get an increase in the serotonin release. We get blocked depolarization of the ECA afferent nerves and changes the action potential of the cell. In other words, non-noxious stimuli don't cause a response as fast as they would if, we did not have that action. So look at all these areas that laser therapy creates in the body by this biochemical, and they're all acting simultaneously. So if you saturate that tissue, every cell that you basically, or every tissue that you apply laser therapy to, these things happen. So let's go back to our pain pathway, and I've got my non-steroidals and my locals and my opioids on there. Let's show where the laser therapy comes in, and you're going to see that it affects a lot of areas here just with the application of light. And we wouldn't really can't hardly fathom that. I mean, that's almost science fiction stuff, but the literature is there and it's proven over and over and over again through the years. We get a decrease in the bradykinin levels, we get an increase in the beta endorphins, which works, to stop that inflammatory reaction. We get a decrease in substance P, which basically inhibits that transmission of those noxious stimuli. We get an increase in serotonin and acetylcholine, and then we block the depolarization of the CA afferent nerves, where these nerve fibers are actually, these peripheral nerves are actually transmitting that substance to the spinal cord. Again, another beta endorphin works along in the spinal cord and in the brain. So again, non-steroidals, one little area of action. A lot of our other pharmaceutical things that we have available now, like gabapentin and tramadol and those other things, have different actions. I just picked those three that are most commonly used, and not that opioids are commonly used, but close to that same mechanism of action. But I wanted to stress the point that laser therapy works in a lot of different ways to help provide the state of analgesia. Now, one of the things I want to make sure that everybody understands, and this is kind of a take-home pearl of wisdom, that when possible, you want to treat at a high dosage along the spine and target the dorsal root ganglion, and then follow that nerve pathway down to your localized treatment area. And I'll give you a good example, carpal tunnel in a person. If you want to really treat carpal tunnel well, you're going to start at the cervical spine, and you're going to basically hit that dorsal root ganglion and then follow the nerve all the way down to the carpal canal. So again, you're doing all those things, all those biochemical cascade of events that I just talked about, not only at the spinal cord, but we're basically interrupting that pathway that I just outlined there. And again, that's a lot of this is based on Juanita Anders' research. I can't imagine. I mean, her papers have to number close to 100 between her and her group. And she's at the Uniformed Services University of Health Sciences, Bethesda, Maryland. And basically her mission is to help basically recover injuries to the neurological system, nervous system. She's done a lot of studies on penetration of the skull in people. And again, you can take all the things that she's learned. She's spoken for me at several meetings that I've conducted and everything. Wonderful person, just a brilliant person. She was past president of the American Society of Lasers and Medicine and Surgery. So let's talk about, now we know how it works. Let's talk about how we get it into our pain management protocols. What we want is pain-free, fast recovery. Remember, stress kills. So we want to eliminate stress. We want to eliminate that pain so they recover the fastest. Most of us already know many approaches for multi-pharmaceutical approaches to this. We all provide good nursing care and post-op rehabilitation. But now let's add laser therapy, photobiomodulation therapy to this. So when we have acute pain and trauma, we're using all these things: burns, otitis, dental problems, osteoarthritis, all the phases of surgery, which I'm about to go in here thoroughly here shortly. So we're having a multimodal approach. We're giving them, I always said, I don't care whether it's east or west. All I want for my patients is the very best. So if you can add laser therapy to what you're already doing, it's an adjunct. It will, and I'm going to show you some research here about, how you can reduce some of the nonsteroidals, for example. That one paper deals with that. But basically, it's one more thing that you can add, one more tool in the toolbox to help us control the pain in our patients: dermatological, abdominal, respiratory, and renal. And we're going to go through all these here. And again, you want to integrate laser therapy in as many ways as possible to all your pain management protocols. And I'm going to show you why that helps. So acute pain management, of course, the biggest, application of that is in surgery and dental procedures. I think otitis should be third, not burns, but I don't have these in any order. And again, chronic management, biggest is osteoarthritis in our geriatric patients. And not, having those two different categories really shouldn't be, because most of our geriatrics do have OA. And then, dermatological disorders, respiratory disorders, but also, how do we use this in our rehab programs? How do we use this in our regenerative medicine programs? I'm going to touch on that towards the end of the lecture. So let's start with surgery, because a lot of people, maybe if you own a laser now, you started right off the bat by lasering your incisions after closure. But I'm going to show you that that's part of the application that you can perform. So we're talking about routine spays and neuters. We're talking about orthopedic, traumatic, dental extractions, anything that benefits, pain management will benefit and accelerate the healing process. And what you see on this picture here is a cystotomy. And you can see that the little blue light on there, that's infrared spectrum, how it shows up on, how red shows 630 nanometers shows up on a visual photo. And you can see that they're lasering that incision line. And I've done this many times. And you'll actually see that whole bladder basically not be as inflamed, not be as red, not be as angry for what you want to do. So you're already starting that, because that target is right there. You're not contaminating your surgical field, but you're able to apply photonic energy right to the target tissue. And the benefits from that, you will see how much faster these people heal and how well they're doing afterwards. And it's simple. That's how you start. I mean, you can add an additional fee to your surgical procedure. We're going to talk about that later. But let's talk about all three phases of surgery. So preoperative, they actually approved several studies out there, and one in particular was over 100 subjects. They basically lasered an area before they did a laparoscopic incision, and they found that those areas that they lasered before the laparoscopic incision healed faster, and they experienced less pain post the procedure than they did when they didn't get it. So again, there's a lot of literature on there. I picked a paper here of basically that has to do with the dental surgery. But again, we do dental surgery, so it applies to us. And again, intraoperative, I just showed you that cystotomy, but there's a lot of other intraoperative areas where you can apply laser therapy, and you might never would have thought of it, because, we're all worried about our sterile field, our surgical field. We don't want to contaminate our surgeries here, but you remember, you can treat off contact, and the beam will absolutely reach your target, and the target's right there, usually. And then post-operative. Again, there's a lot of applications post-op, and I'm going to go through a case here in a second to show you. I mean, the most common application that is being used in our profession is, of course, lasering the incision line, but you can do more than that. Okay, so I'm going to give you some examples here. Here's an bowel anastomosis, and before it's, the anastomosis is complete, before the bowel is dropped back into the abdomen, you basically administer some photonic energy to it, and you know what a bowel looks like. This was one where a foreign object was removed, and of course there was a lot of damage to the bowel tissue, so a little bit had to be resected and then sutured together, and you can see the inflammation come out of it right before your eyes. You can see the area, basically the circulation start to be reestablished and the inflammation start to disappear. Again, most common use is over the incision site. Now, this is a good example. This is a dental extraction, and you can see, look how inflamed the mucous membranes are here. They're all red and inflamed. Of course they are. I mean, these are horrible teeth and, need to be extracted. And the dog was under general anesthesia. You can see it's intubated here. And this is taken 30 minutes after the surgery was completed and laser therapy was applied to the incisions. So notice that you'd expect those incisions and that gum to be really red and inflamed, just like it was before taking the teeth out helps a lot, taking all the infection away, but you would still expect to see quite a bit of inflammation there. And you can see on this one that just a short time later, you can see it. I had my own tooth extracted here about a month ago, and I'm not a wimp about pain, but this hurt. And so I actually administered the laser to my own incision line on my own bottom jaw. And when I went back 3 days later for my surgeon to check on it, he said, "Man, you've really healed fast." And I just, like the Cheshire cat, just smiled and said, "Yep, I'm a good healer," And it wasn't that. It's because I applied laser therapy twice a day the first day, and I got an immediate pain relief from that. So that's personal experience. So let's do a case here. This is a 9-month-old female spayed Chihuahua, a vascular necrosis. So we're going to do a femoral head and neck excision here. So there's the radiograph, and you can see that's well warranted in this case here. Now, here's an important concept. We think, we put them under general anesthesia, but that doesn't imply that they're under analgesia. The animal is unconscious during the procedure, but it still perceives that stimuli from surgery because the drugs used to block the pain pathway, noxious stimuli are still causing the wind-up pain is still experienced. There's still a perception in the brain, even though they're underneath general anesthesia, that they're in pain. So again, exaggerated pain upon recovery. So how do we stop that? So preoperative, again, this case here, we did the area of the incision, the surrounding musculature, and the target's right there. So you don't need a high dosage, 2 joules per square centimeter. Constant rate of infusion of morphine, lidocaine, and ketamine, and intra-articular bupivacaine. And again, that's what was done pre-op. Intraoperative, we administered a laser to all the exposed tissue before closure. In other words, the procedure was finished, we excised the femoral head and neck, and then lasered all the tissue that we traumatized during surgery at 4 joules per square centimeter. We increased the dose there because we're not just treating the dermis here, we're treating deep into the musculature that we just exposed in surgery. And then again, post-op, we administered immediately to the incision and the articular musculature around it. Again, you don't need a whole lot of dose there. And then again, the secondary part where this dog's going to wake up and he's not going to bear weight on it right away. So you know that he's going to compensate with other muscles. So you actually laser those of the back and thigh area before, right after surgery, before he has a chance to compensate and strain that musculature. Post-recovery, whatever, you want to do pharmacologically, and then apply the laser therapy to the incision therapy. And a lot of times you don't get to do this more than maybe the day after surgery because they go home and people care for them at home. And you want to apply it to the incision area, again, 2 joules per square centimeter, and all the periarticular musculature, but also include the other hip, because the other hip is where he's putting all his weight on. He's straining it. A lot of people will laser just the incision site, and they're forgetting that now he's putting, all offloading all that weight from the area that you did surgery onto the other side. So let's talk about acute. So we talked about surgical. Now we're going to talk about acute. So acute musculoskeletal pain, back pain, limping, toenails, sprains, strains, all those things. Dermatological pain, hot spots, abscess, wounds, anal glands, otitis, anything that ends in IS. acute gastrointestinal pain, parvovirus, pancreatitis, colitis, and then urinary pain, cystitis, pyelonephritis, urinary obstructions. All these things are presented with a patient, and then they are presenting with acute pain, whether we can realize it or not. So let's look at a couple of cases here and the protocol of what was done with the laser. So here's a cat that jumped on a hot stove. Probably won't do that again. And again, you might think, well, that's a burn. Should I put a laser light on a burn? And yes, it's used at a lot of burn centers here in the United States. I know that for a fact because I've actually been to a couple of them and watched them and helped guide them on what they were doing. And you will absolutely see, and just think back to my mechanism of action here, how that would help to accelerate the healing of a burn and take some of the painful away, because that is a very painful condition when you burn yourself. It hurts like crazy. So, if anything we can do to do that is good. So otitis, you can treat off contact, which is the, external part of the ear there, the pinna, and just inside the ear there. You don't want to, get your handpiece all messed up with all the gunk and exudate that's in there. But then you can treat, on our patients, you can treat on contact by going outside the ear and treating the ear canal from outside, because you are going to get penetration down there much deeper than you can by putting topical applications in there. And again, that helps. You'll notice if you do that, and you do that basically, with a high enough dosage, the dogs will almost immediately, one of the first things the client will observe is they stop shaking their head, because it just doesn't hurt as much. Yes, cleaning out the ear and applying whatever pharmacological or whatever you do to manage those kind of cases helps, but there's also a difference once you start lasering them in addition to that. Cervical disc pain, again, our target is deep. So again, we have to use a higher dosage to saturate down to that tissue, and you know how much pain that is. Now, here's a case where I wanted to put something up there, which, sometimes people feel that that's a contraindication, is to laser right over an injection site. And yes, that's true, because it's on the side of prudence. We don't know what happens to pharmacologically to a lot of our medications or vaccines or whatever we do. But when you do have a reaction, you can laser them 24 hours later, 8 joules per square centimeter. This is a reaction on a dog that Dr. Godbold had in his practice of a post-imidacide injection. And again, most of those do react, with a little bit of cellulitis afterwards. And again, you can see again, the 24 hours later, how much that's improved just after one treatment, okay? Urinary tract pain. Again, positioning the patient is very important, because we want to get that handpiece right next to our target tissue. So if you hold the cat up in the air, and I'm using a cat, you can have a dog too, but you want to hold it up so that the bladder is right on the other side of the abdomen from the handpiece. So that's a position. But again, you've got to use a high dosage. You want to give them enough energy there, because look at all you have to go through. And if the bladder's got some, urine in it, of course, we want to basically that's an incidental absorber of light. So we want to make sure that we can saturate the whole bladder as much as possible. So again, that's the reason for more of a higher dosage. And the same thing goes for gastrointestinal pain. And here you treat them on lateral recumbency, one side at a time. So you're going to give 8 to 10 joules per square centimeter, and even higher with a larger patient, on lateral recumbency. And if you don't believe me, the next time you suffer from some kind of virus or something, you want to make sure and try it on yourself. I'm going to have to speed things up here a little bit. So again, chronic pain management, anything that lasts longer than 1 month to stimulate, may be persistent, like osteoarthritis, and may be absent. It might be a CNS, like a malfunction, like degenerative myopathy, for example. And again, chronic arthritis, chronic dermatological conditions, chronic respiratory, chronic GI. This was a study, and I'm not going to go into it much, but basically they took 2 groups of dogs. This is Janice Huntingford's practice in Canada, published in a peer-reviewed journal. They were able to reduce the non-steroidal anti-inflammatory dose in 9 out of the 11 dogs, though, in that group that received laser therapy, but none of them, they couldn't reduce it at all in the group that did not receive it. So osteoarthritis, again, don't just treat where they hurt. Don't treat our primary, but treat all your secondary compensatory areas. Again, use a good high dose, because we want to treat, just think how difficult it would be to treat this joint that I have up there on the radiograph. We want to treat it circumferentially around the whole joint. And again, we would have to compensate for incidental absorption, and we want to put it through range of motion if possible. That really helps, because just think about it. If I move that joint through range of motion, and I'm moving my handpiece at the same time, or even if I have a stationary handpiece, I'm reaching more cells. I'm reaching more target cells there. And then I've had The occasion sometimes to treat mega mammals, and there you want to start with a dosage of about 40 to 50 joules per square centimeter. I've actually used on elephants over 100 joules per square centimeter. When they're arthritic, they are very arthritic, and most of our elephants that are in captivity are quite old, so they do suffer from osteoarthritis just like we do. Here's another infrared thermograph, and I want to show this targeted treatment again. So it provides a roadmap on where to treat. So if you do have infrared thermography available to you, that identifies that area. Look here, treat here. Those increased thermal gradients, those areas are red and yellow on day 0 there, are going to receive most of the treatment. If you're applying it to the whole back, you can see that up towards the shoulders there's not so much inflammation going on. So it's all the energy that you provide is going to do more good, even though that entire box there, that rectangle, was the treatment area. And then you can see, you can objectively monitor the progress. So it allows treatment areas that would benefit the most, and it allows an accurate quantitative and qualitative monitoring of the patient's progress. Not only was the patient better clinically, but we could put a percentage on it. We could say, okay, the inflammation has been reduced by this percentage. So our thermal emissions are reduced by this much. You know, most of the time our measurements were subjective. Well, how's Spot doing today? Well, he ran up the steps for the first time. Well, that doesn't give you near enough information to change your dose. And again, there's a lot of times on this study, we use 20 joules per square centimeter on contact, and less hyperthermia will be equal to less inflammation. And again, it didn't work on all of them. This animal here, he actually increased his energy, emissions, but why he did that is he was moving more. When we first took day 0, you could hardly get him to stand up, and on day 7 he was actually walking around quite easily. Chronic otitis, again, this is daily, 2-3 times a week, every other day, at least 2 times a week, and then maintenance is needed. And we all have those patients in our practice, and a lot of times they came from another practice because that person never cleared them up, and you're not going to clear them up either. Sometimes owners are just very difficult to satisfy. But if you add laser therapy to everything you're doing, it's going to help alleviate that pain. The patient's you're going to take some of that inflammation and swelling out of there, so all your other topicals and pharmacological substances can do a better job. Stomatitis, that's one that you don't get a really over 90% response efficacious rate on this. And again, I think that's because of the autoimmune component with this. But in this particular case, you can see that there was a big change even after 6 treatments over 2 weeks. This was at 30 days after the initial treatment, so 2 weeks after the last laser therapy. But sometimes those will come back. So again, let's treat a case here. DJD of coxofemoral joints bilaterally, 8 years duration. We had an aggressive phase where we gave at least 3 treatments, 8 to 10 joules per square centimeter. This dog weighed 40 pounds, and initiate treatment along the spine and follow nerve pathways to the hips. But this practitioner also applied laser to all the acupuncture points to help, add to that efficacious result, and it does. So then you go through a transitional phase where you basically are reaching a plateau and you want to make sure it stays there. So you're doing it twice a week, both hips and lumbar muscles, and you're going to constantly evaluate before each session. And then you have to find out what the maintenance level is. Is it once a month? Is it once a week? Is it once every 2 months? And every patient is different, and every client compliance is different. But this gives you an idea how to put and initiate laser therapy into the management of pain on this patient that has had this problem for 8 years. This is a very interesting case shared with Dr. Godbold and I from Dr. Thorsen in Norway. And again, I honestly, before his enlightenment here, I honestly had not thought about using it for asthma, freeline asthma. I had used it on a lot of, infectious problems in the respiratory system, but not asthma. And again, it provided pain relief, it reduced the inflammation, and it improved the quality of life. But you have to use a pretty good dosage. And then 3 out of 4 out of first 4 days, and then 3 times per week, and then once a week to manage. And he said he had about an 85% success rate after about 6 to 8 treatments. In other words, and there's the after shot, and you can see that the lungs have a lot of the consolidation, a lot of the swelling, a lot of the lung has changed really graphically quite a bit. Now, Ron Hirschberger had basically used his own clients for a study, and he did when he told me about this and presented this at a lecture I was at. He had already collected data on over 100 cats, and he found out that it really was helping these chronic renal disease patients. And he would basically administer the laser at all angles, at least 3 vertebrae above and 3 vertebrae below the kidney tissue, and he'd also do the lymph nodes. And this was the only time that I honestly can lay my hand on it and say that twice daily helped. And you can see the difference in the patient. And then twice weekly until the creatinine stabilizes, and again, maintenance levels to effect. And how do you know? You monitor your blood chemistry results. Feline chronic, and if you think about it, why it works is we get a release of nitric oxide, which reestablishes the neurological function there. So we get a vasodilation where before it was vasoconstriction. We get serotonin and endorphin release, and I'm simplifying this greatly. But you can, now that you understand how we provide pain relief and what this does biochemically release, is that you can understand how it helps these patients, not only with the pain management, but just getting better. You stimulate their appetite, you improve their quality of life, you alleviate the depression, and you're relieving pain. That's a big one. Same thing goes for the dogs, our canine patients. Same type of treatment. And he felt that 10% of the canine pet population in his practice developed kidney problems. He practiced up near Boston, Massachusetts, so in the northwest part of our country. And again, twice daily for the first 3 days, or 3 out of the first 4 days, twice weekly till the treatment goal is reached, and then maintain. Other painful conditions, IBDD, again, higher dosage because our target is deep, hard to get to. Degenerative myopathy, they found out if you applied laser therapy to all those areas, you're basically trying to reopen those nerve pathways to that tissue so it doesn't degenerate so fastly. It's similar to a lot of the neurological problems we have in people like ALS. So they're basically, you're not only treating the area where they're offloading their back weight, but they found with the Kirkland study that they basically increased the quality of life 4 to 5 times what it was without applying laser therapy. And a lot of that was analgesic or pain control to a lot of the areas. Pancreatitis, again, high dose, and this works really good on smaller dogs. When you have a large dog, that's a little tough to localize where the pancreas would be and hit it with the beam. But on a dog that's, say, 30 pounds and white hair and white skin, not so hard. And you'll really see a difference in your blood chemistries. Liver disease, same thing. Smaller dog, a lot more efficacious than when the dogs get bigger. And chronic dermatological disorders. I mean, those things are painful. Lick granulomas, for example. We used to treat those with 5 joules per square centimeter because we thought it was very superficial. And then we found out if we increased the dose to 30 joules per square centimeter, we got more serotonin release, and it broke that basically that compulsive, incessive compulsive behavior that, contributed to the formation of these things. And then, our feline lower urinary tract disease patient, again, positioning is important. Acupuncture doesn't take many joules to stimulate your superficial acupuncture points, just 1 to 2 joules in the feline, but up to 150 to 200 in the equine. The deeper you get, the more joules you need. But again, with a laser and the right technique, the circle the dragon, treat them cranial caudal, dorsal to ventral, and treat any active trigger point, it doesn't take long to treat a half a dozen, 2 dozen points, whatever you want to do. When you incorporate it into a physical rehab program, again, you're modulating pain to perform the physical rehabilitation. A lot of dogs come in, and if you start doing stretching or core exercises on them, it's painful for them. So you laser them first. You perform your rehab procedures or protocols and then laser them again, maybe. You're not going to overdose them on laser therapy, but you're going to see a big difference on again, you're decreasing inflammation, you're promoting healing, but again, physical performance and decreased muscle injury with photobiomodulation therapy, but it relaxes the patient before these sessions. A lot of them come anxious anyway because it's a different area. They're not at home and they're not comfortable, just like we are. And what happens is they get more relaxed, and you can make more progress with your physical rehab program. Regenerative medicine, we want to harvest and prepare the cells. So if you apply laser therapy to an anatomical area prior to collection, it goes the same way when I said applying it pre-surgically before you make that incision. You're going to get an increased blood supply there. What's going to happen? You're going to harvest more stem cells because you have increased blood there. So when you do that harvest and you do the aspiration, you're going to get more cells there if you laser them ahead of time, and pain management to the harvest site. So here again, I'm using a pain management procedure, but it also helps collect more blood cells for your PRP and your regenerative medicine procedures. And then when you inject both intra-articular and systemically, a long time they said, well, don't laser that joint after you've injected PRP into a joint. And they found out that was a little bit of a myth, because there's a lot of people that I know. One guy in Australia that's treated over 1,000 of these, and he's done them all at 24 hours post-administration of the injection. So don't be afraid to use this in conjunction with your regenerative medicine. Let's talk about fee schedules. Basically, raise the surgery fee. That's an easy way to pay for your laser if you do a lot of surgery. In the United States, I've seen everywhere from a $5 to $20 increase, depends on the length and the complexity of the surgery, of course. I converted it to euro, but my conversions here were a few months ago when I did it, so I'm not exactly sure what the price of the euro to the dollar is right now, but I'm just giving you a general estimate there. On-site and acute case, so usually 40 to 60 US dollars for one site, 35 to 55 euro. And then when you have multiple sites, you don't increase it, you don't double that, but you increase it a percentage, usually 10% or whatever, because you already have the laser out, everybody's ready, the dog's positioned, you know, you have everything under control. So it doesn't take you that much more time to do more sites. And what you do when you do more sites is you're going to see an increased response to your therapy. You're going to see a better clinical response. So let's talk about, you know, when you have a chronic case, have your clients prepay the therapy. You can do that all the time, but especially with a chronic case, because clients are a lot more compliant when they've already paid for it. They'll come back in. So if they buy, I know that it's going to take at least 3 laser therapy sessions, I would save them 5% off. And people will write 2 checks for a smaller amount and 1 check for a big amount, because it's just human nature. So you might want to say, okay, I know it's going to take 6 treatments, and because if you're going to pay them, I'm going to give you a 10% off for 9 treatments. And again, here's a dysplastic hip. We did 3 sites, aggressive phase, 3 sessions in 1 week. So 80 US dollars per session because of the 3 sites, and then transitional phase of twice a week for 2 weeks, and then a maintenance of once every other week. Total of 9 sessions for 720 US dollars, 810 euros. And if they get a discount of 15%, it comes all the way down to 612. So you're almost saving, you know, over 100 US dollars here. So that's a big savings for the client, and they're going to be compliant with getting it. So in summary here, utilize laser therapy as pain management tool in practice, and it's scientific evidence-based, it's versatile in surgical, acute, chronic applications, even your regenerative medicine and your rehab practice. And it's no longer, does laser therapy work for this? We know it works for this. It basically, what you should be asking, am I aware of all the efficacious uses in daily veterinary practice where I can use it? That's what you should be asking. And I'm hoping that I basically expanded all of your horizons who are attending today and all who listen later, and help you provide pain management for our patients. So any questions? I have a little bit of time here that if any came in on the chat line or any that came into Nanomedical there that I can take time to answer them. Otherwise, you can email me at aimladbm@aol.com or email Nanomedical, and if they can't answer it, they will forward it to me and export. And again, the only dumb questions are those that you don't ask. So an experience with all of you with whatever you have, and I've been getting quite a few questions from the result of these webinars from over in Europe, which expands my knowledge. Exchange information, the more we interact and the more we basically, the better we can take care of our. Thank you.